Fantastic. So we have the pleasure today of having Dr. Richard T. Liu with us, who's a clinical psychologist and specializing in self-injurious thoughts and behaviors and depression in childhood and emerging adulthood. His research program focuses on characterizing dynamic processes of risk, underlying onset and recurrence of self-injurious thoughts and behaviors and depression in youth and young adults. His programmatic interests lie in advancing our understanding of SITBs, self-injurious behaviors and depression from who is at risk to how and when they are most at risk, thereby directly informing risk assessment strategies and yielding potential targets for clinical intervention, as well as characterizing risk in a high priority at-risk population, sexual and gender minority youth. He is currently the principal investigator of 3 NIMH-funded studies involving computational modeling of ecological momentary assessment data and ambulatory measures of psychosocial stress, sleep, and physiological arousal, as well as neurocognitive markers of short-term risk for suicidal behavior in adolescents, the whole darn picture. That's not something Richard added, I added that. Serving as director of big data studies in the depression clinical and research program at Massachusetts General Hospital, and the director of suicide research in the Division of Child and Adolescent Psychiatry at Mass General. He holds a faculty position in the Department of Psychiatry at Harvard Medical School, and prior served as associate professor in the Department of Psychiatry and Human Behavior at Alpert Medical School of Brown University. It's such a pleasure. I can't wait. I have my notebook open to take some notes. So I will hang up or put down my mic and transfer over to you. I'll mute myself and let me know. Are you okay with getting the slides up?
I believe so.
Okay, yeah. Great. Thanks.
All right. Let me know if you can see it. Okay, great. Well, thank you for that very kind introduction. And I'm very honored and excited to be here to present some work in the area of suicide prevention youth. Some of my own work, but also just kind of just to give you all a sense of the state of the field in terms of where you are in terms of prevention and treatment for youth suicide. It's not moving. Oh, there we go. Okay. All right. To start off, I want to just give you a general overview of what I'll be covering today. The first is to characterize the scope of this issue as a public health concern. I will be presenting some findings on the epidemiology and phenomenology of suicidal thoughts and behaviors, including its prevalence, course, and temporal trends in youth. In doing so, I'm hoping to make clear why suicide and our intervention efforts to reduce it is of particular concern in this age group. It's obviously of concern in any age group, but it's why we really need to intervene early on. Second, I'll focus on some developmentally relevant considerations in terms of risk factors, and also populations that may be particularly at risk for suicide-related outcomes in youth. The next, I will present some suicide screening strategies that for teens that have been developed over the last 10 or so years. Finally, I'll cover some suicide intervention strategies that have been developed for intervening at times of acute crisis. And I also talk about the evidence-based a little bit to support these. So I want to first begin by presenting some data on suicidal thoughts and behaviors in teens. These data are from the Youth Risk Behavior Surveillance System, or the YRBS. Just for context, the YRBS is a survey that's administered by CDC every few years to high school students across the country. It's intended to provide a nationally representative snapshot of a variety of health and risk behaviors relevant to this age group, just to kind of see where we are as a country in terms of reducing risky behaviors. Among these behaviors are suicidal thoughts and behaviors. And I've included exact wording of the questions asked here because I think that's important. The first question asks about thoughts of suicide. It asks, during the past 12 months, did you ever seriously consider attempting suicide? And you see the rate here is quite high. Roughly 1 in 5 teens endorse experiencing some suicidal thoughts. There are 2 things that make this high rate even more concerning, and which I want to emphasize. First is that it's just asking about the last 12 months, meaning that lifetime rates of suicide thoughts would presumably be even higher. And second, we're not just asking about fleeting thoughts, passive ideation, wish to be dead. We're asking about having serious thoughts of killing oneself. So taking these together, it's really concerning that in over a 12-month span, this many teens are having these kind of thoughts. We see with 12-month prevalence rates of suicidal plans is only a little bit lower, not that much less. Finally, we have suicide attempts in just the past 12 months, also considerably high. Just under 1 in 10 teens have attempted suicide at least once over a 12-month span. With these high prevalence rates, we can imagine how many teens are currently or recently struggling with suicide, or may very well know of a friend or peer who may be struggling with these thoughts and behaviors. So there's also some evidence to suggest that things have only gotten worse during the pandemic, over time in general, but particularly during the pandemic, and that the mental health impact of the pandemic may have made these kind of parents even worse. There's also evidence to suggest that the pandemic has affected the mental health of lots of people, but there seems to be a pattern where it seems to be hitting people more the younger you go down in age. So for example, there's some data from the summer of 2020 at the kind of the peak in some sense of the pandemic from the CDC, which found that 1 in 4 18 to 24-year-olds, which is the youngest age that was surveyed, had struggled with serious thoughts in just the past 30 days. So just a very concerning high rate. And what we found, what we could see in this data is that unfortunately that's the youngest that they went, but it's the pattern that I discussed where it seems to be the pandemic seems to be hitting people harder the younger they go. This held true for suicidal thoughts and behaviors. All right, so I want to present some prevalence data that collapses across the age here. I present some prevalence data that collapse across the age. And what I want to see is kind of what happens if we look at patterns over age, over time. This figure is from a study conducted by Matt Nock and colleagues at Harvard, using nationally representative data from the National Committee Survey, the Adolescent Supplement. The x-axis is age in years of the participant, and the y-column is the cumulative prevalence rate for first onset of suicidal thoughts and behaviors. What we see is that prior to adolescence, suicidal thoughts and behaviors are reasonably rare. And I'll just add a little caveat to that later. But what you see is that it really starts to really shoot up around the onset of adolescence. So kind of one indicator that adolescence is really kind of a time to really intervene. In this figure here, these are based on epidemiological studies in a review from Matt Nock and colleagues. We see that the rates of suicide attempts in the population level on the y-axis, and we see over on x-axis is gain the age brackets. What is very clear is again kind of a real peak in terms of suicide attempts in late adolescence and early adulthood. This is true for males and females, and we see the well-known trend of suicide attempts being more common in females than males across any age group until we hit later into adulthood. So as for the course of suicide, suicidal thoughts and behaviors, we have some data to suggest there's kind of an escalation or a kind of a worsening trajectory over time, particularly as one progresses from ideation to behavior, but also in terms of recurrence of behavior. What we see is that a sizable proportion of teens who experience suicidal thoughts do progress to form suicidal plans, and over half of teens with a suicide plan end up acting on those plans. And the vast majority of teens who have suicidal thoughts or plans go on to make an attempt within a year's time. This tells us something about the window in which we really need to intervene with teens if we are to prevent teens from progressing to actually having a suicide attempt. So in terms of progression from suicidal thoughts to behavior, we could talk about temporal progression, within person temporal progression. We know that one of the strongest predictors of suicidal behaviors is past occurrence. This is true for adults, and it's true for teens. We see that those who progress we see that those with a history of suicide attempts are 6 to 8 times more likely to have a future attempt. But what's also concerning is that there's evidence that suicidal behavior may follow a progressively worsening course as one transitions from adolescence to early adulthood. So there's one study by David Goldston and colleagues at Duke that followed a sample of teens following discharge from psychiatric inpatient care all until young adulthood. What the study found was that after age 17 to 18, the majority of suicide attempts were repeat attempts. Not only that, the interval of between successive attempts decreased with each attempt. And the degree of suicidal intent, the severity of suicidal intent during a given attempt, appeared to increase as a function of the number of past attempts. So it really suggests that there's a worsening course over time, and again speaks to the need to really intervene with individuals early on, which often is during the teenage years. So when taken together, it really suggests that our biggest potential impact in terms of bending the curve with regards to this issue really is about adolescence. That being said, I will add the caveat, which I kind of alluded to before, of we're seeing, unfortunately, concerning trends with pre-adolescents as well. Historically, there's this view, even among clinicians and researchers, that suicidal thoughts and behaviors doesn't occur in the pre-adolescent years as a function of children being that young, not having the cognitive capacity to really understand death and suicide. Unfortunately, we're seeing that that is not the case. And there's data from the CDC to suggest that this is worsening as well in preteens. In 2008, it was one of the 10 leading causes, emerged to become one of the 10 leading causes of death. And as of the most recent data, I think it's from 2019 or so, we see that as of that time, it became the 5th leading cause of death, even among preteens. So it's really seems to be suggesting that it's starting early and earlier, which is a particular concern. So this is just focusing on teens, but I will talk about temporal trends at the population level in terms of suicidal thoughts and behaviors across age and within person over time. So here we're looking at suicidal thoughts and behaviors that have changed at the population level. These are temporal trends data taken from the YRBS, spanning a 27-year period from 1991 to 2017. This is taken from a study in pediatrics from 2019 by Lindsay et al. This graph presents 12-month prevalence rates of suicidal thoughts on the y-axis and year of data collection in the y-axis, x-axis. Each line represents a separate race and ethnicity, and a dark blue line kind of buried somewhere in the middle there represents the general US population. What we see is across all sex and races and ethnic groups, there's a significant linear decrease in self-reported suicidal ideation, so a positive trend in that sense. From the same data in the same study, we have similar data for suicide plans. Across all sex and race and ethnic groups, with the exception of non-Hispanic multiracial individuals, we see a significant linear decrease in terms of self-reported suicidal plans across time. And now we have temporal trends in terms of suicide attempts. There's a significant annual decrease in suicide attempts among adolescent girls, but we don't see a significant trend in terms of boys. Overall, the natural rate of suicidal thoughts, plans, and behaviors seems to be, in general, going in the right direction, which may suggest we're making progress regarding reducing suicidal thoughts and behaviors in teens. But these are just general thoughts, behaviors, and what we see, however, is a different trend in terms of what we think of in terms of clinically severe or medically severe thoughts and behaviors. So this is a study that really got a lot of press when it first came out in pediatrics. What we see is, what you can already see here is a different picture in terms of different trends. So these are data from 31 children's hospitals across the country. Y-axis is the percentage of all ED or inpatient visits across these hospitals that were due to suicidal thoughts and behavior. And the x-axis is the month and year of the visit, spanning from 2008 through July 2015. What this study found was that hospital visits for suicidal thoughts and behaviors had doubled over this 10-year period. And we could split this across in terms of age, as you see here. And what we find is that this is largely driven by adolescents, more so than pre-adolescents. But this pattern of increase held true in terms of significant increase both in terms of late adolescence and early adolescence. This is the same data again, stratified by sex. We see a general increase for both boys and girls, but with more of ED and inpatient encounters for girls relative to boys. So this is looking at suicide deaths. All the data presented so far are looking at ideation, plans, and attempts. And we see for suicide deaths, this is from the CDC, that in the age group of concern, adolescents and a little bit into young adulthood, suicide is the second leading cause of death. And I already kind of talked about suicide being an increasing cause of death among preteens. And these are the same data again, but now across multiple years, looking at trends over time in terms of suicide deaths in this age group. And what we find is that at the national level, suicide rates have been increasing since 1999, with a brief dip in the middle, towards the end, 2018. And the national suicide rate has been increasing over 30% over this time period. In this graph, I limited to individuals 10 to 17-year-olds. Y-axis is the rate per 100,000 individuals, and the x-axis the years. And we see that the suicide rates have been increasing over time across all individuals. So this pattern holds true if we stratify by sex. Top line is for males, and the bottom line is for females. In contrast to what we saw with suicide attempts, we see that females are less likely to die by suicide, but more likely to attempt than males. This is a very common and widely known trend. And the reason for this is that males are more likely to engage in more lethal means. If we kind of look at this data a little bit more closely, we see that some of the greatest increase in suicide rates have been found in early adolescence, in this case, particularly in the 10 to 14-year-old age group. Here are some data stratified by sex, with male again presented top line, girls on the bottom line. Since 1999, for this age group of 10 to 14-year-olds, rates have doubled for boys in terms of death by suicide and quadrupled for girls. Collectively, we're finding that we're actually going the wrong direction when we look at medically serious and more lethal suicidal behavior in youth. So some questions that naturally come to mind to help address the issue of suicide in youth are, what are some things that put teens at risk? And are there any particular subpopulations among teens or communities in teens that we should be particularly mindful of with regards to suicide risk? Teens that would benefit from more in terms of investment in resources, in terms of screening and monitoring risk, and kind of support in terms of preventing engagement in suicidal behavior. It won't be obviously possible to cover thoroughly treatment of these questions in terms of multiple risk factors, in terms of multiple populations. So I'm going to focus selectively on a couple key ones that I think are particularly relevant to this age group. So I'm going to be focusing on bullying, particularly cyberbullying, and I'm going to be focusing on LGBT youth, but just focusing first on bullying. There's general support for an association between life stress and suicidal thoughts and behaviors, with evidence of this strengthening as one goes from suicidal ideation to attempts to death by suicide. For all forms of suicidal thoughts and behaviors, the evidence appears to be strongest for interpersonal stressors. And there's evidence to suggest that interpersonal stressors may not simply be a risk factor for suicide behavior, but may be a precipitant or trigger, an imminent risk factor for these outcomes. And there's one study in particular that I kind of like that illustrates this, by Courtney Begg at the University of Michigan and colleagues, that this is with adults, but we do see this pattern with teens. They looked at adults admitted to the hospital right after a suicide attempt, and they did a thorough assessment in terms of life stressors on an hourly level, looking backwards in time to 48 hours immediately before the patient's suicide attempts. What they found was that patients were significantly more likely to experience a life stressor, particularly an interpersonal life stressor, in the 24 hours immediately preceding their suicide attempt compared to the 25 hours immediately preceding that. Although this study was conducted in adults, there's lots of reasons to suspect that interpersonal stressors may be simply relevant a risk factor and a precipitant in teens as well. We know, for example, from a developmental perspective, that as individuals transition from childhood to their teenage years, peer relationships take up a lot of relevance and prominence in their lives. Peer evaluation becomes something that is a concern for lots of teens. And just peer relationships and kind of peer networks social relationships is just a big part of teens' lives, as we all know. There's also neuroimaging studies to show that even at the biological level, there's an increased indication of sensitivity to these relationships and evaluation. One common form of interpersonal stressors for teens with a peer evaluational component is bullying. And so if we kind of look at social media, that's often kind of a thing that people think about. A form of bullying in terms of social media is cyberbullying. And so a question that has drawn increased attention in recent years is the potential mental health impact of cyberbullying on teens. This falls within a broader concern of how social media use may affect teens' well-being. In part to address this concern, these questions, some colleagues and I, headed by Jack and Nisi over at Brown, have conducted a systematic review and meta-analysis on all the studies that have been conducted so far on any aspect of social media use in relationship to self-interest thoughts and behaviors. We've found in total a number of 61 studies in this area, most of these focusing on cyber victimization. In contrast, despite a lot of societal focus on frequency of social media use, we found that few studies have looked specifically at this question in relationship to suicide, and that overall there doesn't seem to be a significant association between the frequency of social media use and suicide-related outcomes. We've found significant and large associations for cyber victimization in relationship to suicide, particularly self-injury-related social media use, and as well as problematic and addictive social media use. This suggests that rather than general focus on social media, it's really more kind of like social media is a general broad construct. It's important to think of the specific ways in which people use social media in relationship to these mental health outcomes. If you think of that, that applies true more generally, like concerns in terms of using the computer, in terms of TV usage. It may be not so much usage period, but exactly how people use it. I keep forgetting to click these things through, but all right. So I'm going to talk now about a subpopulation of youth that seems to be, unfortunately, at particularly elevated risk for suicidal thoughts and behaviors, and which, as I mentioned before, I think that we really need to invest more resources and effort and focus in terms of reducing risk for this population or these populations. And I'm focused particularly on sexual and gender minority youth. So sexual and gender minority individuals have been identified as at greater risk for negative mental health outcomes in general, and this does include suicide. As for why that may be, one prominent theory, the minor stress theory model, suggests that sexual and gender minority individuals are chronically exposed to greater stressors in the form of stigma, prejudice, and discrimination. And this exposure is specifically related to their identity, experiencing stigma, discrimination, and victimization, particularly because of their identity. And this higher exposure to stressors is what in turn puts them at risk for a variety of negative mental health outcomes. We can understand how these very stressors these very types of stressors may confer risk for what we consider these mental health outcomes because they are inherently interpersonal stressors in nature. So some members of my lab and I want to know how have we been doing over time in terms of addressing risk for these outcomes, suicidal thoughts and behaviors in sexual minority youth. We're particularly interested in looking over time at temporal trends in the prevalence of these outcomes among sexual minority youth relative to heterosexual youth over a 23-year period. So what we did is we looked at data from the YRBS for Massachusetts, and the reason we chose the reason why we looked at Massachusetts is because Massachusetts is the first state starting in 1995 that really looked at these items, particularly look at asking questions about sexual orientation in youth. The YRBS has, in more recent years, started to ask these questions at the national level, but Massachusetts was the first one to do this starting in 1995. So it allowed us to look at trends over a kind of a very long period of time at a population level. So we were able to generate prevalence data representative students in grades 9 through 12 in the state of Massachusetts for every other year from 1995 through 2017. And we looked at trends in terms of suicidal thoughts, plans, and attempts over this period. And we looked at sexual orientation in two ways. First, we looked at sexual identity, how people self-identify, and we also looked at same-sex behavior. It's important to look at multiple indices of sexual orientation, particularly in youth. Some people may engage in same-sex behavior, but not self-identify as a sexual minority individual. Additionally, there may be some individuals who do identify as a sexual minority individual, but have not yet engaged in any same-sex behavior or maybe any sexual behavior at all. And this is particularly relevant for talking about teens, because the size or proportion of teens have not engaged in any sexual behavior whatsoever. So we employed a statistical technique called joint print regression, which allows for determining if there's a significant trend over time and there's been a significant change in trends over time. So starting first with suicidal, what we found was that the prevalence rate was very high, regardless of sexual orientation. Additionally, the rates were consistently higher among sexual minority youth than among heterosexual peers. And this is true regardless of whether we looked at sexual identity or sexual behavior. We see that 12-month prevalence, or about a third of sexual minority teens had endured some form of suicidal ideation. And about 1 in 10 to 1 in 3 heterosexual peers experienced suicidal ideation. So again, quite high regardless, but much more elevated among sexual minority individuals. So this graph clearly illustrates how persistent disparity has been between sexual minority youth and heterosexual youth over time. The years indicated on the x-axis, the year in which the teens were sampled, and the prevalence rate is presented on the y-axis. The top line is for sexual minority youth, and the bottom line is for heterosexual peers. We see a significant decline over time in suicidal thoughts for both sexual minority youth and heterosexual youth, with a plateau in the case of the heterosexual youth starting around 2007. But this decline is steeper, statistically significantly steeper among heterosexual youth than among sexual minority youth, even with that plateau. And these findings hold true regardless of whether we're talking about sexual minority status based on sexual identity in this graph, or sexual behavior in this graph. So when we turn to suicidal plans, we again see higher rates among sexual minority youth compared to heterosexual peers. Again, this is true regardless of whether we looked at sexual identity or sexual behavior. As you saw with suicidal ideation, the disparity is quite pronounced and persistent across time. We see a significant decline for both in terms of suicide plans for both sexual minority youth and heterosexual peers. Again, we see that plateauing effect starting 2007 for heterosexual youth. We again see a significantly faster decline among heterosexual youth than sexual minority youth. And again, this find holds true for sexual identity and sexual behavior. Now we turn to suicide attempts. We see, again, concerning high rates of this outcome, regardless of sexual orientation. But the 12-month prevalence rate is what's much higher among sexual minority youth than among heterosexual peers. So again, the same general patterns we've seen for ideation and plans. Again, when we look at sexual identity, there's a persistent higher prevalence, among sexual minority youth compared to heterosexual peer. So that a disparity that we've been looking at, noticing so far. The rate in both cases have declined significantly over time. However, unlike with suicidal ideation plans, this rate of decline was not statistically different between sexual minority peers than heterosexual youth. And we got largely the same results when we looked at temporal trends for suicide attempts with sexual behavior. So in summary, we have some good news and we have some less than positive news. The good news is that we see in general the prevalence rates of these outcomes have declined over time. But again, with the caveat as before, these are looking at general ideation and plans and attempts, not looking at medically serious or lethal behavior. This mirrors the findings I presented earlier in that regard. These temporal trends declines held true for both sexual minority youth and heterosexual youth. So that's all generally positive signs. The not so great news is that when it comes to reducing health disparities among sexual minority youth, we have not been making such great progress. First, the prevalence rates remain remarkably higher, high in general, but remarkably higher. And even the most recent year of data in the study, about a third of sexual minority teens experience suicidal ideation, and 1 in 10 have attempted suicide. So just very concerningly high. Second, we see that the prevalence rate was consistently higher among sexual minority youth. And not only that, the disparity may actually been increasing over time in the case of suicidal ideation and suicide plans, based on the steeper decline that we see among heterosexual youth with these outcomes. And this fact is more telling when we consider that we have seen the least improvement in the group that has the greatest room for improvement. So it should seem like it should be easier to have more of a decrease among sexual minority youth than among heterosexual youth, and yet we're seeing the greater movement improvement with heterosexual youth. What makes this all the more concerning is that this is happening despite sustained efforts from the National Institute of Health and the National Academy of Medicine since around the turn of the century, since around the start of some of the graphs I presented earlier, since around 2000, to promote research to address these health disparities among sexual minority and gender minority populations, particularly in case of self-interest thoughts and behaviors. I'm going to turn briefly to some data I have on non-suicidal self-injury, or NSSI, defined as deliberate self-harm without suicide intent. NSSI is an important clinical concern in its own right, but has taken on increasing clinical importance since it was discovered around 2011, 2012, around there. That is an even stronger predictor of future suicidal behavior than is past history of suicidal behavior. To contextualize why looking at NSSI in sexual and gender minority youth is important, in a meta-analysis that some members of my lab and I had conducted a couple years ago, we found that not only is the prevalence of NSSI markedly higher among sexual and gender minority individuals, but this is even more so the case in teens, as you see in the orange box. That is, the risk for NSSI in gender and sexual minority teens compared to heterosexual peers is much greater than the risk for NSSI in sexual and gender minority adults compared to heterosexual adults. Again, looking at the YRBS data for Massachusetts, looking at temporal trends in the NSSI prevalence stratified by sexual orientation over time from 2005 to 2017, we can look at to see what progress we're making here. The reason why these data are from 2005 as opposed to earlier is because that's the first year in which NSSI data was collected. As a case for suicide, across all youth, regardless of sexual orientation, we see that there's alarming high rates of NSSI. However, for sexual minority youth, we see higher rates than we do among heterosexual peers. There's no decline in NSSI among sexual minority youth, regardless of how it's defined, based on self-identification or behavior. In the case of heterosexual youth, however, at least based on sexual identity, there has been a significant decline over time. I would just like to add that there are some resources available for sexual and gender minority individuals, particularly youth who are struggling with thoughts of suicide. Some of these are relatively new. They've been around for a few years, but I think they're helpful resources to have. I listed some of them. I could mention that these are collected through the American Foundation for Suicide Prevention, a list of resources that they collated. And the relevant link for that is at the bottom of the slide here. The Trevor Project offers a 24/7 hotline for LGBTQ youth. They also have a text and chat line that teens can use. And that I think is particularly important because teens we find are more likely to engage in these resources through a kind of a text or chat line than through kind of traditional calls or over the phone. There's also now a 24/7 hotline specifically for transgender youth that you can see there at the bottom of the slide. And I'm also happy to share these resources again afterwards after today if helpful. So there's a question now of how do we, what can we do in terms of preventing suicide? We could talk about suicide prevention in terms of screening and in terms of intervention. This includes addressing gaps in screening for suicide risk, as well as crises and brief interventions for suicide in cases where a person might flag for risk. And for this latter, I'm going to focus more on safety planning and suicide means restriction and crisis lines. In terms of strategically addressing gaps in suicide risk screening, a good point to start is to think about where are the main contact points for suicidal teens. One setting which we would see a lot of individual teens are in medical settings. Over 80% of youth see their primary care physician at least once a year. Rather than the percentage of teens passing through primary care, perhaps maybe even more strategic to think about the percent of teens that pass through a given setting. It looks like the primary care settings is again the setting to consider, with the vast majority of teens, about 86%, visiting their primary care physician within a given year. If we expand to other settings like the ER or inpatient settings, 8% of teens who die by suicide have contact with one of these settings within 3 months prior to their death. Medical settings appear also to be placed to find those who may be at short-term risk for attempting suicide. So collectively, these findings suggest that medical care settings are an important point of contact for screening teens who may and help to identify those that may be at risk and in need of treatment. So for screening for suicide risks, we still have a fair way to go. This is reflected by a report from 2014 from the National Action Alliance for Suicide Prevention and NIH that lists 12 aspiration goals to guide research with the aim of ultimately reducing suicide. Aspiration goal number 2 is to determine the degree of suicide risk among individuals in diverse populations and diverse settings across diverse settings through feasible and effective screening and assessment approaches. Supporting the use of suicide risk screening in medical settings, the Joint Commission has found that number 1, suicide is one of the 5 most frequently reported sentinel events. Number 2, under detection of suicide risk is a leading cause of these sentinel events. And therefore, the Joint Commission issued a sentinel event alert recommending screening of all patients in medical hospital settings for suicide risk. The American Academy of Pediatrics has issued a similar recommendation, particularly for youth, calling for the use of suicide screening instruments that are easy to use and therefore easy to train, easy and quick to administer in these settings. So very really focused on translational value of these measures. So when we talk about suicide screening and asking questions about suicide specifically, it's important to think of what may be hurdles that may be encountered. So a common concern that arises whether simply asking about suicide may put the thought of suicide in a teen's head. So this is a common concern that is encountered. And although this concern may come up a fair amount, there's ample amount of research to this at this point to show that there's no basis for this concern. Simply asking the suicide does not increase the chances that people will start thinking about suicide. So there's this concern that it's a kind of an iatrogenic effect, and there's many other studies since this, but this is a landmark study conducted by Manangu and at Columbia and some colleagues in 2005, published in JAMA. So what they did is they found that high school students who were given a suicide screen were no more likely to experience suicidal thoughts after screening than students who did not receive the screen at all. When analyses were restricted to high-risk teens, defined by teens with depression, substance use, or a suicide attempt history, they found that administering these suicide screens that those who were administered these suicide screens were no more suicidal after screen than before. Rather, students provided the suicide screen seemed to be less distressed and less suicidal than those who did not receive the screen. So they conclude based on these findings that there is support for rather than against screen for suicide risk in teens. There are several suicide screening instruments that are currently available, and the Joint Commission has provided recommendations for several. I'm going to focus on two of the most prominent ones, and I would argue two of the better ones that are out there. The Ask Suicide Questionnaire, or simply called the Ask, and the Columbia Suicide Severity Risk Rating Scale, or the CSSRS. The Ask was developed by a group of researchers led by Lisa Horowitz at NIMH, and the CSSRS is led by a group of researchers and clinicians, particularly Kelly Posner and colleagues at Columbia University. The Ask is meant to be intended with the practical use in mind. So the suicide screens need to be rapid and easy to administer, and they need to be quick and easy to interpret for them to be practical in terms of use. And of course, they also need to be validated. And the Ask has been validated for teens and as well as adults, and includes 4 core questions, yes/no questions. And there's a 5th question that is asked based on positive endorsement of any of the first 4. And it's very quick. It takes about 20 seconds to administer. In terms of evaluating suicide screening measures, we can look at both sensitivity and specificity. Sensitivity is the probability of a positive screen when administered to youth at risk for suicide, who are generally at risk for suicide. And specificity is the probability of a negative screen when administered to youth who generally are not at risk for suicide. That is important because we don't want to be causing families unnecessary distress by telling the teens are at risk for suicide when they're not. So both specificity and sensitivity are important. Since the Ask is so brief, we can look at it right here. The first 2 questions are asking about recent passive ideation or thoughts about wanting to be dead. And so the 3rd question is about recent active ideation or thoughts of wanting to kill oneself. And then the 4th one is asking about whether the person has a history of attempting suicide. Positive endorsements of these is the 5th question, asking about current active ideation. As you can see, the Ask lays things out very succinctly in terms of the next steps based on whether question 5 is asked and as well as the responses to that question. An evaluation of the Ask was conducted with patients from 3 pediatric ED settings across the country. And this includes 344 medical patients and 180 psychiatric patients. Overall, 18% of teens or youth screen positive, and just under 1 in 20 medical patients screen positive as well. In contrast to about just under half of psychiatric patients. What's found was that Ask demonstrated good sensitivity and specificity. Its sensitivity was 96.9% and specificity was 87.6%, as you can see here. The Ask, I could also mention, is freely available. The NIH website actually has what they call an Ask toolkit, which includes a broad array of resources relating to the use of Ask, as well as the measure itself. It includes info related to the use of Ask, particularly in a variety of different medical settings, which I think is very helpful. So things like the ED versus inpatient and private care settings. So moving briefly on to the CSSRS, another widely used instrument. There are several different versions of the CSSRS, including a version for screening purposes. This quick screens tend to gauge the severity and immediacy of suicide risk. And so again, it's very brief, so we can present right here. As you can see, there's 6 quick questions, and it provides a kind of a useful color coding system to indicate the severity of risk based on patient responses. The first question is about passive suicidation, second about active, third is asking about any active ideation with method, and the 4th is asking if there's any intent to act on the thoughts, and the 5th is asking if there's been any suicide plans. And finally, the 6th one is asking about preparatory acts, such as stirring pills, stashing blades, that sort of thing. Oh, there's actually a question here. Okay.
You can feel free to answer it at the end.
Okay, great. And if you forget, please do ask them again. All right.
I'll keep track.
All right, thank you. So screening positive means a patient has a symptom that requires further evaluation. It doesn't mean that they automatically go to inpatient care. So that's just important to note. Screening positive for suicide risk indicates that there's a need for further psychiatric evaluation by a trained mental health professional who can kind of get more detail evaluating what symptoms exist, assess for risk for self-harm, and to provide what necessary guidance may be warranted to the primary care physician, as the case may be, or whoever is asking for this follow-up. And also just general appropriate disposition decisions depending on the level of risk. And also to, as much as possible, to connect the patient with whatever mental health treatment may be warranted or needed. And again, just to stress, it does not necessarily mean that they go right away to inpatient hospitalization. It also doesn't mean that someone needs to monitor the teen 24/7 after screening for risk. So it's basically, it's not an all or none sort of thing. And that's important to note because often there's that misconception or misperception, I should say. All right. Okay, where's this? Oh, because I have to click off here, there. Okay. All right. So in an international group of child and adolescent psychiatry consultation liaison providers formed the Pathways in Clinical Care, or PAC, work group, which is kind of you could think of it as a committee under the ACAP, the American Academy of Child and Adolescent Psychiatry. So this committee was formed to address this challenge, this pathway from risk to the indicated treatment, as the case may be. So just to kind of walk you through this kind of pathway, what does this look like? So we kind of talked about the screener, meant to be very quick and easy, brief 1-minute screener, not much training required, and not much needed in terms of interpreting the results. So if an individual, if a teen or adult, actually, as the case may be, screens positive, it's followed with this kind of safety evaluation or suicide safety assessment conducted by a mental health professional. And this is meant to take about 10 minutes of time. So it takes longer, but it's also not meant to be kind of an inordinate long period of time. And if things progress from there in terms of concern of risk, then a follow-up fuller evaluation of roughly 30 minutes is indicated, rather than an outpatient referral, or as the case may be, potentially no being required. So just in terms of what this looks like in terms of flowchart, this is taken, if you want a copy of this, and there's others like this is on the Ask Toolkit website. And it's also in appendix to this article if people want to look at this in more detail. As I mentioned before, they have a version of this for different settings. This one is for the ED setting, as you can see in the, I don't know if you can see my mouse cursor, but in the top right. And it's kind of really helpful in terms of kind of bringing out the flow chart of all the different decision points that one takes. I'm not sure how I could see this font. It's a little small, but basically, they present to the ED, they're given the screener, and then if they screen positive, there's all these decision points. They have this the suicide screen, the BSSA, and then based on that, kind of the different decision points that are made afterwards, imminent risk versus high risk versus low risk, and what these all look like. So it's a very kind of handy tool, I think, for people in terms of really kind of having a good sense of what the different steps in the path look like. So, we talked about screening, and now we could talk about intervention. So we could talk about safety planning, is a commonly used one and widely used practice for intervention with individuals at elevated risk for suicide. As a suicide crisis is typically time limited, the idea is that suicidal thoughts may diminish over the passage of time. So safety planning aims to prevent the individual from acting on suicidal thoughts during this crisis until it dissipates. So it includes things like helping the individual recognize warning signs, using internal coping strategies like distraction, and accessing social support resources, including contacting mental health professionals, and restricting available means that for self-harm. So just very quickly, this is kind of what a safety plan looks like, and there's electronic versions of these as well. There's an app version of it as well. And the idea is to plan these things out ahead of time for the individual to use when they're in crisis, because as this holds true for anyone, when we're stressed out, it's hard to kind of think things through than when we're calm and collected. So the idea is to kind of save as much of this thinking for the individual for them ahead of time. So when they're in crisis, they don't need to think as much and you can just follow through the plan. And also, of course, to kind of help them notice warning signs before things escalate to a crisis. So there's some research looking at how effective are these things, and there's this paper looking at safety planning intervention and other kind of like looking at that relative to other possibilities. And what they found is that there's a 45% decrease in suicide behaviors using safety planning interventions, and approximately halving the odds of suicide behaviors over a 6-month period after the intervention. And intervention patients were found to be have double the odds of actually attending an outpatient mental health visit afterwards. This is actually a positive thing because often we see there's a disconnect in care following ED visits. So the higher usage of this less intensive outpatient care is actually a positive outcome. So we also have means restriction, and it's kind of how it sounds, trying to kind of take away means of engaging in self-harm. So again, thinking of the suicide crisis as kind of a time-limited thing, so that when people are in crisis, it makes it hard for them to act on these thoughts so that it will dissipate before they have a chance to find means to engage in particularly lethal means. Lots of research in this area has focused more on adults. So there unfortunately hasn't been evaluations of this in teens. And finding crisis lines, we kind of talked about a couple earlier. There's some research showing that it does have a positive impact in terms of addressing suicidal crisis severity. And these are just some resources I just want to share. They're out there. I just going to leave things at that, just to make sure that we have a little time for questions. But I'm happy to share these resources as well. And I just want to also mention there's let's see, yeah, it's right there. 9A is a relatively recent resource that has been rolled out as an alternative to 911 for suicide crises. Just very quickly, there's research suggesting that brief interventions, such as these, are helpful in terms of reducing risk for suicide attempts and assisting linkages in care after the crises. And just want to end there, so we have at least some minutes for some questions. And thank you for listening.
This was wonderful and so comprehensive. So appreciate all the work that you've done and all of the resources that you've laid out for us. So thank you. And I'm looking at the chat to look for questions. There was a question about screeners to use and differences. So one question, Megan Marie Thomas, if you're still on the line, you can go ahead and ask your question yourself. You can unmute if you're able to.
Yeah, thank you so much. So I was just curious, I work in the pediatric primary care setting, and we utilize the PHQ-2 initially, and then depending on what their score is, I want to say 4 or higher, then we do the PHQ-9. Mm-hmm. Would you prefer, or do you think it's better to use the ASK, or what are your recommendations?
Yeah, I know different people think of different things, like in terms of even simply recommending screening for suicide in pediatric setting. And I think some, and I know that there is, how it's called, all these acronyms. There's a group that had recently made recommendations that suggested that there's the evidence base for screening for youth isn't there, but I think suicide experts may differ regarding that, especially based on the data I presented. I think, we definitely also want to screen for depression as well. So, if the idea would be, if you're going to use the ASK in place of PHQ-2 and not have a depression screener, then I would not recommend that. but I'm also kind of mindful that, during in primary care, like there's lots of things going on. It's very busy, and there may be limited time for screening. If you had to just use one screening system, I would say PHQ-2, so that you get depression as well. And I know the thing you're talking about, PHQ-2 followed by PHQ-9. I think there's a JAMA paper in support of that. But if you have room to do both, I would recommend doing the ASK in addition to PHQ-2, and that way you kind of hit depression and suicide risk, both of them.
Perfect. Thank you so much.
Shelley, you had a couple of contributions in the chat. Would you like to unmute?
Sure. The AAP has a new blueprint that talks about suicide screens for in pediatric primary care. And they do recommend the ASQ, and then they have some recommendations for if it's positive to use the ASQ, BSSA, and the Columbia suicide, as well as the safety.
Yep. Yeah. And yeah, so that I think suicide researchers would agree with that completely. So I'm glad that that's there as a resource.
Dr. Liu, this might sound a little obtuse of me, but bear with me. Where do you find the sweet spot between your safety plan and doing a 5150?
Yeah, so the safety plan, I think it's just, I guess kind of depending on context, but I think it's helpful to have it as a resource for, it can be during crisis, but not necessarily during crisis. If there's someone's at risk, I think it's helpful to have as a resource. And what we often do is, especially for teens, kind of have it available on their phone. What we also do is we try to, towards that on safety plan, there's people to contact, and to have them input those numbers on their phone. And they could kind of change the wording for privacy reason. If other people play on their phone, it doesn't have to say suicide crisis. It could be their own kind of personal code. And I think that's kind of helpful that we do with teens, so that they don't have to kind of punch here, or kind of they're stressed out and their fingers are shaking and they're trying to punch a number and get the wrong number and deal with all that stress. I think just given the evidence base, for teens that are at risk, I think it would be good to, in general, to have that available for them.
Appreciate that. Thank you. Other questions? Oh, we're at 1 o'clock already. That went by fast. So I appreciate your time. Thank you everyone for joining us. Please join me in a warm goodbye, and thank you to Dr. Liu for presenting this material. There's totally room to contact you, right?
Yes, for sure.
Follow-up questions. So thank you so much. Everyone have a great day. Take care.
Thank you so much. Right. Bye.
Bye.